It's one of my most favorite stops. I have the opportunity to travel here for the Middle East, and one of the nights that I see many familiar faces that I remember from my last visits. I'm asked to address, I think, a very relevant and important topic, which is reducing risk for cardiovascular disease, managing factors. And I think one of the most prominent risk factors, as a lipidologist, maybe not surprising, is cholesterol. What I like to do is to address a few issues with you that are relevant when looking in the past, what we learned about cholesterol management and why it has become so prominent in risk reduction, a little bit about the present, and also something exciting about the future, because as I'm speaking right now, at the American College of Cardiology conference in Orlando, Florida, one of the most prominent studies will be brought as a late-breaking clinical trial. If I calculate correctly, that will be at 5 p.m. Kuwait time. So I'm unfortunately not able to share that data with you, but I can share with you some data from what we hope will reflect on this trial as well. So, as I said earlier, we are really focusing to reduce atherothrombotic disease, and I think in my past visits I've learned this is a major problem here in this region, partly because of the diabetes, obesity issue, partly also because, as every country in this planet, we are faced with an epidemic of atherosclerosis. This is the classical, not picture, but actually a drawing from Netter in the 50s, showing you the exterior of an acute event and the trigger factors: exertion, cold, just coming out of a dinner, a male in his end 50s, early 60s. Those were the features highlighted in this slide. I also like to show you this slide because this shows you a coronary artery, a dissected coronary artery, and very prominently you see the riskful features, which is the yellowish plaque form. And that yellowish coloration is caused by lipids, and the lipids carried by lipoproteins. Now, cholesterol has been controversial from the moment it was discovered in the late 1800s, 1900s, and there have been always a lot of proponents and opponents regarding the relevance of cholesterol in developing atherosclerosis, but even more important so in reducing atherosclerosis. Now, these are the modern criteria that have to be fulfilled before you can say this is really causing the problem. And that means it has to be plausible, it has to be strong, graded, first the factor, then the disease, independent, consistent, agreement between different disciplines, Mendelian randomization studies, and reducing the factor reduces the risk. All these can be ticked, and we can safely conclude that LDL cholesterol, and certainly a high level of LDL cholesterol, causes devastating cardiovascular complications. Now, not only the occurrence of atherosclerosis have we discovered is related to the complications, but also reducing cholesterol really pays off. If you have a drug or a diet that can reduce your LDL cholesterol, the percentage LDL cholesterol reflects the percentage of risk reduction. And this is the famous CTTT analysis, looking at primary prevention, looking at secondary prevention, and quite clear. Now, one of the really intriguing factors of cholesterol, when we compare it with other risk factors, is that we know that blood pressure management or glycemic management has a sort of J-shaped curve. If it's high, it's bad, but if it's too low, it's bad again. And there is a sort of optimum point where you try to aim your patients. And as you probably all know, for diabetes, there have been really violent discussions if it should be below 6.5 or below 7.5, especially with the new guidelines coming out. Now, with cholesterol, we do not see that plateauing. We do not see that J-shaped curve. So far, with the follow-up of all these different trials and the changes in guidelines, the risk still seems to be graded, and we haven't reached the bottom yet. One of the things you could ask yourself is, if we don't see a bottom yet, is it maybe because we're not reaching the normal levels yet? And I think that is a very astute observation. Because what we normally define as normal is that you measure the whole population, and then you get a bell-shaped curve, and then you say, this is the 50th percentile, 2 standard deviations left and right, and we have a normal distribution. Now, the fact is that what we think is normal is actually already abnormal. And let me show you some, I think, convincing data, at least for me, that underline that. Don't worry, I have in control. So, this shows you 3 animals, and we belong to the group of mammals. These are sheep. Now I have to calibrate it again. Yes. So here we have the sheep. Oh, yes. Sheep, pigs, and here we have humans. And what they show is plasma cholesterol level on the y-axis, where you see the level of total cholesterol, so not LDL, of total cholesterol. That is before birth, and then right after birth, and during the rest of the lifetime. And what you can see is that before birth, all these mammals share the same total cholesterol. It's around 50 to 70. And then after birth, you see a sharp rise in cholesterol, and the reason is that because there's a big change in the diet. We go from nutrition from the placenta, now we get mom's milk. And mom's milk is high in fat, high in calories, and you can see that in all animals that rises to a higher level. Now, if you are a sheep or if you are a pig, after you have been breastfed, your mom kicks you out and says, okay, now you have to take care of yourself. You're not my responsibility anymore. But in humans, we have a different situation, because after breast milk, we get cow's milk. And after cow's milk, we get a Western diet, and the consequence is our cholesterol stays up. So I like to make the assumption that a physiological cholesterol is somewhere between 50 and 70. So that means that an LDL cholesterol in a normal range is between 30 and 50. And if you have these levels, it's virtually impossible to develop atherosclerosis. And the normal levels we see reflect the fact that we all suffer from atherosclerosis, and half of our population dies from atherosclerosis. So a physiological LDL is, total cholesterol is between 50 and 70. And we can see the consequences already at an early age. This is a young boy, 3 years old, who died in a car accident, and they did a post-mortem exam, and they already found fatty streaks in his coronaries. Did he have a very high cholesterol level? Or was he smoking? Or did he have diabetes? No, he simply had a normal, between brackets, cholesterol level, giving him the first stages of atherosclerosis. Is that unusual? No, it's not. This is data from the Bogalusa heart study. Look here, 2 to 15-year-olds, 50% have fatty streaks, and 8% have already atheromas. In the 16 to 20, it's already 1 in 3. So it's not really surprising that in the 50s or 60s, we start to see the events. Now, this is the natural process of atherosclerosis, here depicted schematically, and here depicted in slices of the coronary arteries. And what I would like to draw your attention to is that the first phases of atherosclerosis, up until around here, is still reversible. That's when there is only the influx of the lipoproteins. But after this phase, you get a response of the cellular tissue, influx of macrophages, inflammatory response, calcium deposits, and this is not reversible anymore. It can be mitigated, we can reduce risk, but the process has damaged the anatomy, and the anatomy cannot be repaired by simply reducing cholesterol levels. Now, one interesting concept I'd like to share with you is what we call the cholesterol burden. We always measure cholesterol at one time point, and that's what we reflect as a signal of risk. But it's not the measurement in one time point, it's sort of your lifelong exposure. And if you take a threshold of 9 grams, so if in your whole life you have been exposed to 9 grams of LDL cholesterol, that is the moment when you see or when you start observing complications. So to give an example, a typical American with an LDL of 150 will need 60 years to get to 9 grams, and that's when the threshold is reached and you see the symptoms. If you are an FH patient, homozygous, and you have very high levels, say of 900 milligrams, then you need only 10 years. And we know exactly that's the age where they get their first complications. If you have slightly lower levels, it takes a little bit longer to develop these complications. To illustrate that it is a big difference if you have a slightly lower cholesterol at a young age between lowering cholesterol in your 40s or 50s or 60s, I like this slide. We know if we take a statin and we take a low dose and you reduce cholesterol by 30%, you roughly have a 30% low risk of complications. In this population of the Dallas Heart Study, they found that individuals had a mutation in the gene called PCSK9. And if you had that mutation, your cholesterol was on average 28% lower than your fellow compatriots in the trial. So you would expect that the risk for cardiovascular disease would also be 30% lower. Look and behold, we found that there was almost a 90% lower risk. So reducing cholesterol at an earlier age gives you a much better outlook for the future. Instead of 30% risk was a threefold, it was 90% lower. So let's extrapolate this. Let's have a simple 40-year-old and we find his LDL cholesterol is 150. Now, let's assume he wants to become 80 years and he is already past 40 years, right? So that means 40 times 150 means that he has now 6 grams exposure of cholesterol. If he wants to live 80 years, that means he has 40 years left and about 3 grams. So 40 years and then 3 grams means that his cholesterol must be lowered by 50 grams per deciliter. That means he has to go from 150 to roughly 75 milligrams per deciliter, and that means that you need roughly a 50% reduction of your LDL cholesterol, and that means to get that, at least 80 milligrams of atorvastatin. Different scenario, let's say he started not when he was 40, but when he was 20. So when he was 20, his LDL cholesterol was 150. Now, he still has 60 years left, and that means that in the 20 years, he had exposure to roughly 3 grams. So that means 6 grams over 60 years, his LDL needs to be reduced to 100 milligrams per deciliter. And for a 30% reduction, which is approximately 45 milligrams per deciliter, we need only 10 milligrams of atorvastatin. So the earlier we start, the cheaper it is, but the better the outcome. Had we started when he was really very young, when he was only 10 years old, well, his LDL cholesterol at that age would probably be 100 milligrams per deciliter. So that means he had still a lot of leeway, almost 80 grams left. To reach 80 grams, you can be 150. So that means over 70 years, his LDL should be around 115. The only thing he needs to do is to increase lifestyle to make sure his LDL doesn't go up to 150, but 115. And had he started even later, had he started when he was already in his 50s, then overall we need a 65% reduction, and that means more treatment. Would he have been older or more at risk, we would have need additional treatment as well. So the point is, the higher the risk, the more aggressive we need to be. We're not scared of being aggressive. This is a famous slide I always show of an unfortunate male who had chest pain, went to a cardiologist, and the cardiologist said, I can help you. What you need is a stent to get you more oxygen in your heart. After the first stent, it didn't work, so he got a second. Still didn't work. He got a third. And in the long run, he got 65 stents, 3 bypass surgeries, and 28 catheterizations in 10 years. And he still had chest pain. So we're not afraid to use aggressive treatment, only we use the wrong aggressive treatment for these type of patients. Let me show you another slide. This was also a person who had chest pain, who went to a cardiologist, and the cardiologist said, okay, I'm going to start you on a portfolio of beta blockers, ACE inhibitors, aspirin, and statins, and we'll see what happens. Of course, the patient didn't return, because if everything goes well, they never come back. But he came back 4 years later, again saying, yeah, after I saw you, my chest pain disappeared, but I still have a little bit uneasy feeling around my chest. So the cardiologist said, oh, that's nice, because now we can repeat everything to see what changes there were. So this was at the initial one, and you can see there was really indications of ischemia, and there was even here a slight or narrowing of the artery. 4 years later, he did a new evaluation, and what you see here is that there was really no signs of ischemia anymore, and that actually the closure, or the narrowing, had disappeared. So his complaints at that point were most likely to be gastric complaints and not cardiac complaints, and it shows you how intensive management of risk factors, particularly cholesterol, really pays off. I'm going to skip this slide for time because I think that makes it a little bit easier. So based on all these data that lowering cholesterol is important and going for lower targets, our guidelines have changed. This was the original ATP3 guidelines with an LDL of 100 and less than 74, very high risk. You know that in 2015, 13 new guidelines came out and newer guidelines in 2015 and 16 and 17. And here we see again very high risk where now not a target, but actually intensity and dosage of statin is prescribed, especially as here, again, a dosage of statin intensity, but not really a treatment target. This is going to change because of the trial data we have now from Improve It, from the Fourier, from the Odyssey outcome. We will see new formulations, not only of using a high intensity statin, I think that will still be bottom line the rule, but also to really try to get patients to an LDL target. These are the new ESC guideline targets where they talk about the addition of non-statin drugs in patients who are intolerant, in patients who are familial hypercholesterolemia, start with a high level. We still adhere to targets, but we have differentiated targets. So less than 70, less than 100, less than 130, based on your baseline risk. These are the most recent guideline from the American Association for Clinical Endocrinology. And now we have a new category. We have very high risk, but we also have extreme risk. And here we can see LDL targets of less than 55. So do we need new compounds to reach these targets? Yes, I think so. Despite having maximum therapy, this is the Prove It trial, 4 out of 10 patients, even with maximum atorvastatin, do not reach the optimal target. So we now have a new type of drug called PCSK9 antibodies. They inhibit or they bind with a protein that has an effect on LDL receptor recycling and also on LDL cholesterol. So what happens is when you give, in this case, alirocumab, which is one of these PCSK9 antibody, as a subcutaneous injection, the concentration will go up very fast, and then next, the free PCSK9, which is involved in the regulation of the LDL receptor, will drop down tremendously and then slowly go up again. And after that, LDL cholesterol will follow as well, and after alirocumab is removed from the plasma, goes up again. Dosing intervals are usually between 2 weeks or between 4 weeks, and what you can expect is roughly a 50 to 60% reduction of your LDL cholesterol. As you can see here, this is placebo, this is 50, this is 100, and this is sort of the standard dosage of 150 milligrams per deciliter. Here it shows you the two dosing regimens. If you give a bi-weekly dosage, it stays fairly a plateau, roughly between 50 to 60% reduction. But if you do interval dosing every 4 weeks, you get a little bit of a seesaw effect. Now we know it doesn't matter what other treatment you give, statin, ezetimibe, diet, you always get on top of that you additional 50 to 60% LDL reduction. So overall, almost 80 to 90% LDL reduction. We had trials that looked at the outcomes in terms of safety and efficacy. Based on these 17 trials and 13,000 patients, there was clear confidence that LDL would be lower, and there were even tremendous reductions in cardiovascular mortality and total mortality. But these were randomized, short-term randomized trials, so not hard clinical data. We needed a really endpoint trial, the Fourier trial, to evaluate in a large number of patients, more than 27,000, to see what happened with cardiovascular disease. Overall, there was again that 60% LDL reduction, and there was a reduction in events, primary endpoint, of roughly, depending on the type of treatment in terms of less than 70 or more than 70, of roughly 30%, and here maximum potency statins roughly 22%. Even in the patients who had a very low LDL, here LDL 0.18 or 10 to 50 milligrams per deciliter, there was still a reduced event rate, and intriguingly there were no adverse events related to these very low levels. The trial we're waiting on today is the Odyssey outcome. This is the one that is slightly longer and hopefully gives us more evidence about the safety. If we compare the Fourier, which was already presented last year, and the Odyssey outcome, one of the biggest differences is that we here have almost all ACS patients, and here not everybody was HCS. Here we have revascularization as an extra endpoint that's lacking here. Number of primary endpoints will be higher in this one compared to this one. Power was similar, maybe slightly less powered in terms of 90 to 99%. These were the first secondary endpoint. These are a little bit higher in the Odyssey outcome, and this were the power calculations. So we expect when we compare these two trials that Odyssey might give us some better outcome. And like I said before, this is scheduled for today at 9 a.m. in Orlando. To summarize, I think these new PCSK9 antibodies are not really targeting primary or primary hypercholesterol mixed dyslipidemia. It's the uncontrolled patients using statins, is the high risk, and particularly the very high risk with progressive ACCVD and patients with heterozygous familial hypercholesterolemia. So that's a little bit sort of the differentiation when PCSK9 antibodies should be started. In Holland, we have 17 million inhabitants, 2 million statin users, and we expect 1%, roughly 20,000, to be eligible for PCSK9 antibodies. Now, statins are what I call the safety belt of cardiovascular risk prevention. Cheap, always present, low technology, no issues about using them, and first and foremost, very effective. However, if you're in a circumstance where there is higher risk, you need to do something extra to protect you. So in high-risk situations, there a statin should be combined with a PCSK9 antibody. To summarize my talk, I hope I've convinced you that LDL cholesterol is really pivotal in the development of atherosclerosis, that we're aiming now for lower targets, 70, maybe 50, but if we start earlier with managing cholesterol, we need not to be so aggressive. Guidelines have accommodated these lower targets, and the safety and efficacy have been determined. The hard clinical endpoint studies, we have now one that's terminated, and the second one hopefully will show us the same things. That was my last slide. Thank you very much for your attention, and I'm here for questions now and after. Thank you.
Thank you, Dr. Peter.